I'm Cesar Castro. I am a faculty co-director for research at the Center for Diversity and Inclusion here at Mass General Hospital. I have the honor of welcoming you to the Center for Diversity and Inclusion Chester Pierce Research Society Speaker Series. This series is actually created in 2014, so 18 years ago, named in honor of the late Dr. Chester Pierce, who was a professor of education at Harvard and professor emeritus in psychiatry at Mass General, where he spent much of his career. So Dr. Pierce was revered by as many students of all backgrounds as ethnic groups as a brilliant, scholarly, kind, and humble professor. Dr. Pierce was a visionary pioneer in the field of global mental health. So this speaker series serves as a platform to highlight the novel basic science, clinical, translational, health services, and disparities researched by our physicians and scientists at the MGH. So thank you for joining us. Before we introduce our speaker, we have a quick housekeeping items to cover. So we set some time for Q&A at the end of the presentation today. So please use the Q&A feature to enter your questions and I'll present them to our speaker. Okay, so without further ado, it's a pleasure to introduce Dr. David Perez. Dr. Perez is a neurologist, a psychiatrist, and a neuroscientist, triple threat here at the Mass General Hospital. He's the founding director of the Functional Neurological Disorder Unit and the F&D Research Program. He majored in neuroscience and behavior and graduated cum laude from Columbia University. He graduated from NYU School of Medicine as a member of the Alpha Omega Alpha Society. He completed Partners Neurology Residency Program in 2011 and the Harvard Longwood Psychiatry Residency Training Program in 2014. He obtained a Master of Science in Clinical and Translational Investigation from Harvard Medical School in 2016. He's a faculty member in the Department of Neurology and Psychiatry here at MGH, and he's developed a cutting-edge interdisciplinary clinical program for the diagnostic evaluation and management of patients with functional neurological disorder, which you'll touch upon for his talk today. In parallel, he's established a research program investigating biomarkers of symptom severity, disease risk, and prognosis in functional neurological disorder. For all his efforts and his accolades, he's been recognized as a fellow of the American Academy of Neurology and the American Neuropsychiatric Association. He's published over 100 peer-reviewed articles, the majority in functional neurological disorder. We actually have one shared publication, David, and recently co-edited a Springer textbook on functional movement disorder. He's a 2016 recipient of the CDI E-Corps Physician Scientist Development Award. So with all that, please welcome our speaker, Dr. David Perez. Just take it away.
Wonderful. Thank you for that very warm introduction. Let me just say to everyone listening in, I'm delighted to be here. Let me share my screen and make sure you can all see my slides. Just give me a moment to move things around. Okay, can you see my presentation well?
It's perfect.
So again, I'm really just thrilled. It's an honor and a pleasure. And today I'm hoping to share with you all a few bits of clinical and research insights into this entity of functional neurological disorder, which really challenges how we think about physical health and mental health in 2022. These are my disclosures. And I really want to begin with a thank you to the CDI, to E-Corps. The Physician Scientist Career Development Award that I received in 2016 was immensely catalyzing to the research program that I was able to develop from the ground up here at Mass General. And there are many things that I'm proud of, but one of the things I want to highlight for you all is that both of my parents were born in Cuba. And one of the things that we think of when it comes to functional neurological disorder is that this is a neglected and marginalized population, a group of patients that live at the borderland between neurology and psychiatry, in many ways forgotten by both fields in the late 20th century and the beginnings of the 21st century. And yet there's been a renaissance. And while the renaissance has many layers, I think one of the biggest issues here that can be very energizing is it breaks down those walls between what we think of as psychiatric disease and what we think of as neurologic disease. And it really challenges also the stigma of mental health that certainly lives in some of our communities. So I want to begin to share with you all a definition of what is functional neurological disorder. And these are patients who present with neurologic symptoms: weakness, tremor, walking trouble, seizure-like events that are incompatible with other neurologic symptoms or other neurologic conditions based on physical examination findings and the review of their motor features. So we use our neurologic skill set to make the diagnosis. But you're also going to hear that it's the psychiatric skill set, putting the patient in context, that allows us to develop a patient-centered treatment plan and also to ask patient-centered research questions. So let me share with you all a few videos first of what we think of as typical presentations of a functional neurological disorder. In this video, this patient has a functional movement disorder with a functional tremor. What you can see is a high amplitude postural tremor. He's engaged in a cognitive task that does not affect the tremor. But now there's a motor task, and that high amplitude postural tremor is basically gone. In other aspects, now the movements of that tremor are time locked to the finger tapping movements. Notice when the finger tapping movements are very slow, that tremor also goes away. Here there's a finger mirroring task. And again, as these ballistic movements are performed, there's a pause in the tremor. These are the rule-in neurologic signs that allow us to make a diagnosis of functional movement disorder. Some patients can present with what we call functional seizures. And here, a subset of individuals can be admitted to the hospital where we can capture a major motor event on EEG and video and see that the brain waves are normal before, during, and after the event. And here's a video of a typical functional seizure. Those initial bicycle movements may have you think a little bit about frontal lobe epilepsy, but now there's a stuttering course. There's a more tremulous movement in the legs. The bicycling movements return with a different amplitude and tempo. Can't see this very well in the video, but the patient's eyes are tightly closed as well. And these are the hallmarks of a functional seizure with a negative EEG. So with this in mind, and with a few snapshots of this entity of functional neurological disorder, the two main themes that I want to cover with all of you today are the following. And we'll begin with this notion of what is neuropsychiatry and why is this perspective important in F&D and frankly in many other conditions at the brain, mind, body interface. So let's begin with a definition of neuropsychiatry. One of my favorite definitions was published in the American Journal of Psychiatry in 2002. And Yudovsky and Hale state, foundational to any definition of neuropsychiatry is the indelible and separate ability of brain and thought, of mind and body, and of mental and physical health. A rejection of brain-mind dualism. And this definition, at least in my opinion, remains the definition of neuropsychiatry in 2022. But let's go back to the past for a moment to think about where we're going into our future. Some of you may know that the leading figures in the early history of neurology and psychiatry, one, many of these figures were working side by side. Many identified themselves as neuropsychiatrists, and coincidentally, many had an interest in functional neurological disorder, previously called hysteria or conversion disorder. I want to share with you all a quote from Stanley Cobb. Stanley Cobb was a neurologist in the Boston area, and he went on to establish the first department of psychiatry at the Massachusetts General Hospital. There are now named Cobb chairs in all the major Harvard teaching hospitals. And here's a quote from Stanley Cobb, deeply interested in this population. I solved the mind-body problem by stating, there is no such problem. There are, of course, many problems concerning the mind and the body and all the intermediate levels of integration of the nervous system. However, what I wish to emphasize is there is no problem of mind versus body, because biologically no such dichotomy can be made. The dichotomy is an artifact. There is no truth to it. And the discussion has no place in science in 1943. So a really forward-thinking vision, some of it realized today, but yet incompletely realized. And for functional neurological disorder, patients that challenge what's traditionally thought of as either neurologic or psychiatric conditions, both fields have some limitations. In part for neurology, what we use to make the diagnosis, in many instances, doesn't translate seamlessly to a patient-centered treatment plan. That's a big gap. Diagnosis does not equal treatment. When we think about the challenges for psychiatry, many mental health providers don't have a playbook to evaluate and conceptualize neurologic symptoms. So what might be a path forward? And that really brings us to the biopsychosocial model, put forth by George Engel in Science in 1977, a really seminal article, a rejection that a singular focus on biomedicine, on pathophysiology alone, will not aid the development of precision patient-centered medicine. That we need to think about biological factors, psychological factors, social, cultural, spiritual factors, how they interact, with potentially the equation being different from one patient to the other. The biopsychosocial model is the playbook that we're advocating, leverages neurologic strengths and psychiatric strengths in thinking about and conceptualizing functional neurological disorder. What gain from this perspective of neuropsychiatry, capital N, capital P? Applied not only to F&D, frankly, but a great range of many other neuropsychiatric disorders. Integrating physical and mental health. 2, mobilizing resources, both clinically and research-wise, including funding. And then maximizing strengths and mitigating weaknesses of having 2 specialties, neurology and psychiatry, addressing the same organ system. That's a unique paradigm in medicine. So in the spheres in which I give these kinds of talks and interact with colleagues, one of the debated topics is, so should we think of F&D as a neurologic condition? Is it a psychiatric disorder? Might it be a psychological disorder? The answer to all of these questions is yes, but with an important caveat. Each of these statements alone is incomplete. The statement that F&D is a psychological disorder without qualification, given how overtly physical it presents, is incomplete in my opinion. And yet the statement F&D is a neurologic disorder without qualification, given what you'll hear about later as well, the importance of psychological concepts, is also incomplete. Prior to the pandemic, and gosh, I just want to acknowledge it's been a challenging few years for many of us. It's so great to have what I hear are 30 students with us this summer. And prior to the pandemic, this article, Medicine's Silent Epidemic. It's all in your head, related to this notion of how forgotten and neglected functional neurological disorder was. But I'm highlighting here in red that my friend and colleague, Matt Burke, who's a neurologist, points out he's a neurologist specializing in neuropsychiatry. And I mention this because neuropsychiatry is not only bringing the biology to psychiatry, it's bringing the psychology and a range of social, cultural factors to being considered to the neurologic patients cared for in neurology. So I hope I've made a plug to think about this intersection to potentially challenge the artificial dualism that's set up in some of our curriculums and in some of our societal framings. And my own challenge of some of this dualistic thinking has really led to some important research insights and the growth of our program in functional neurological disorders at Massachusetts General Hospital. And one of the themes that we've tackled on the research side is this intersection of disease mechanisms and etiological factors or risk factors. And one of the challenges here is that F&D is among the more complicated neuropsychiatric disorders. So it's mechanistically and etiologically heterogeneous. What that means is the personal equation for developing and maintaining F&D varies across patients, albeit there are some important reoccurring themes. Some of the mechanistic constructs that are important in this population include disturbances in emotion processing, disturbances in self-agency, that when we move, we're the authors of our movements, and biased attention to the body, among other processes. And both historically and in modern times, there's been a fair bit of emphasis on the potential relevance of adverse life experiences. And we know that patients with F&D have about a 3-fold increase in adverse life experiences, including higher rates of childhood maltreatment and neglect. But this is non-specific because not all patients endorse such experiences. However, how do we think about the relevance of adverse life experiences when present? And here, a number of studies, including research from our own cohort at MGH, have shown that there's a positive correlation between the magnitude of previously endorsed adverse life events, particularly those in childhood, and the severity of patient-reported symptoms in this population. Not only that, but there are studies that show that individuals who endorse a history of abuse also develop this condition at an earlier age. This data and the data from the past slide really highlight the biological relevance of adverse life experiences when present in this population. I also want to use this slide just to point out that this is not only about childhood maltreatment, abuse, and neglect, but a range of much more subtle life experiences across the lifespan, from relationship challenges to health issues to accidents. And indeed, there's a literature to suggest that some patients develop a functional neurological disorder when they have a minor physical injury, when attention is brought to the body, and that may set off a cascade of brain, mind, body problems. There's a less robust but emerging literature to also suggest that when we think about clinical outcomes in this population, individuals who have a history of childhood abuse potentially may respond less robustly, less positively to the current standard of care that includes both psychological treatments and physical rehabilitation. So this was the background where in 2014, I came on staff at Mass General. My task was to develop both a clinical program in this population and a neuroimaging focused research program. And since this population was so neglected in the research field, there were some major gaps. And despite a 100+ year history of thinking about the potential relevance of adverse life experiences, there were not prior imaging studies that looked at brain symptom relationships and brain trauma relationships in the same cohort. So we sought to do this. We recorded an initial sample of patients with functional neurological disorder. In this particular study, we're looking at gray matter volume. We're performing this through a quantified imaging analysis called voxel-based morphometry. And what we observed was the following: that reductions in the left anterior insula, highlighted in white in the circle on the screen, reductions in this brain area correlated with both patient-reported symptom severity and the magnitude of endorsed childhood abuse burden. An interesting overlap between brain symptom and brain disease risk relationships in this population. In this initial study, we also looked at how measures of trauma that don't necessarily relate to F&D, do they map on to the same neurocircuit profile, or do they map on to a distinct neurocircuit profile? For the sake of time, I'll focus you all on the top portion of this slide, where we were able to replicate that the severity of PTSD symptoms related to gray matter reductions in a different brain area, in what we call the perigenual anterior cingulate. This is a finding that has been robustly replicated in the PTSD field, and it helps add more weight to this potentially novel finding that I share with you all in this slide here. So our efforts continued. We expanded our cohort of functional neurological disorder patients. We recruited a matched, age and sex matched, healthy control group. And we sought now to investigate between group differences, first at the structural level. For simplicity, I'm going to focus on only one of a range of different analyses that we did here. Again, looking at gray matter volume using voxel-based morphometry. And we separated the F&D population into two groups, blue and red, with the blue group being those that had the greatest impairment in physical health, the top 50%, versus in red, the lower 50%, still symptomatic, but less so, with the notion that biological signatures may be present most robustly in those with the highest symptom burden. And what we observed was that only when you looked at the sickest patients compared to healthy controls in green, we were again able to show a reduction in the left anterior insula. For the sake of brevity, I just want to highlight that the insula is part of a core network in the brain called the salience network. It includes the amygdala, portions of the cingulate, the insula, deeper structures, including the periaqueductal gray. And this brain network is involved in a range of functions that could be important in this population, from constructs related to emotional awareness, from a construct that's called interoception, understanding the physiological state of our body. And it turns out that this network binds a fair bit of information, including binding both physical and emotional information, which really in some ways is where this patient population lives. So it's an interesting, not only brain area, but interesting brain network to think about as relevant in this population. Okay, I'm going to fast forward in time a few years and also switching imaging modalities. Here in this slide, I'm going to share with you all a few details on how we looked at the relevance of resting state functional connectivity. It turns out that over the past couple decades, we can tease apart brain networks by having an individual lie in an MRI scanner and engaging in mind wandering without a formal task. And using this resting state functional connectivity approach. And in this analysis, again, looking at how connectivity from the left anterior insula may relate to symptoms. What we found was that connectivity between the left anterior insula and the right anterior insula, between the left anterior insula and the temporal parietal junction, and between the left anterior insula and motor control areas, related in dose-dependent fashion to patient-reported symptom severity. And this resting state functional connectivity profile, we were also able to adjust for individual differences in anxiety and depression, which kind of makes this level of analysis even more robust. I want to take a detour for all of you listening in part because when we think about this level of quantitative brain imaging, you want to think about so what? We're learning quite a bit about the pathophysiology, but is this going to help us in the clinic? Is this going to matter to the patient who's struggling with brain, mind, body symptoms? And one of the analyses that you can do to allow the imaging to hopefully matter in the future, apart from just advancing the pathophysiology, is studying biomarkers predicting clinical outcome. How a brain scan prior to the start of treatment and individual differences in that brain scan, how that may relate to prognosis 6 months later. And we were able to conduct the first study in our field looking at this. Very pilot, certainly preliminary, needs to be replicated. But what we observed was that the connectivity between a subnuclei of the amygdala, the central medial nucleus of the amygdala, how that region related to activation in the right anterior insula predicted prognosis. The stronger the connectivity strength up front, the greater the likelihood that the individual would improve in a multidisciplinary treatment program at 6 months. So this is called predictive biomarkers of clinical outcome. I started this biological journey with making reference to adverse life experiences, and I've shared with you all some potentially meaningful functional connectivity relationships. So in this last study that I want to highlight for the group here, we recruited now a psychiatric control group. Individuals, it was a mixed control group of clinically salient mood disorders, anxiety disorders, and post-traumatic stress disorder. Very importantly, our psychiatric control group was matched to our F&D group in terms of previously experienced childhood abuse burden. And what we observed only in patients with brain, mind, body symptoms with functional neurological disorder was that the connectivity between the amygdala and motor output areas, including the precentral gyrus, and the connectivity between the insula and motor output areas, related to the magnitude of previously experienced physical abuse in childhood. The more physical abuse endorsed, the greater crosstalk between these emotion processing areas and these motor output areas, something we did not see in our psychiatric control group. across these studies, we begin to then bridge mechanisms with etiological factors. We're also highlighting with these scatter plots the importance of individual differences. So with these individual differences, we're now asking the question, actually, if functional neurological disorder is both mechanistically and etiologically heterogeneous, might there be a trauma subtype of functional neurological disorder? And we at present time have an R01 grant to look at these kinds of questions in large scale. I really also just want to leave you all with this message that as we think about brain trauma, symptom severity relationships, these are complex, nuanced relationships. There are both risk factors and resilience factors to consider. That covers both biology as well as environment. And the stress diathesis model is the prevailing model to think about the complexity of these relationships, not only in functional neurological disorder, but a range of other trauma-related conditions. I focused for you all some of our work on relating symptoms and risk factors to brain circuits, but there are a range of other intermediate variables that we need to think about, from autonomic profiles to endocrine profiles like cortisol to inflammatory profiles. And I really want to highlight the work of my postdoc, Sara Perez Echeverri, who did a really nice job in conducting the systematic review and meta-analysis in this area. None of this would be possible, frankly, without the really great team that we have at Mass General. It's we all learn from each other. I think our communication and our collaboration are key strengths. And just a big thank you to the whole group. And thank you to all for listening in, and I'm happy to take some questions. Here's my contact information if you'd like to reach me later as well. Thank you very much.
Dr. Perez, thank you for a very fascinating introduction. I would say it seems like there's a lot to be done. Have multiple careers out of the work that needs to be done, and I'm sure Professor Pierce would have been very proud of you. And so I'm going to open the floor to questions. Please use your Q&A button, I guess I could start in the meantime. So you touched upon this towards the latter portion of your talk, this nature nurture kind of dynamic. And so I was wondering, I guess, since this is not yet a very highly or widely studied field, whether like twin studies or sibling studies are being pursued where one may have had that particular trauma, and to really dissect whether this is more the symptom or the cause, some of these connectivity findings that you see in the brain imaging.
I think that's a great question. Currently, no, there are not large-scale twin studies. This is a nice way of studying these kinds of questions. Ultimately, I think the research community is looking to enhance collaboration, to build large-scale registries, and maybe this will allow for some of this kind of work to be done in the future. Our approach has been that we need to think about moving beyond healthy controls. That includes both neurologic controls and, in our case, psychiatric controls. And if we begin to see some divergent patterns, it won't answer all of the questions that you raised so nicely, including questions related to causality, because they may be compensatory changes, but hopefully it begins to move the conversation forward.
Thank you. Anyone with questions? Dr. Price.
Yes, you may have touched upon this, but it relates to the previous question, I think, in some regard. When you are normalizing or spatially normalizing the brains, have you started building atlases that are disease specific? Do you think that that's something, have you started to do that? Do you do that? Is that something that would make sense in the future? If you,
Dr. Price, that's an astute question. Let me answer a couple. Let me answer it a couple ways. So in disorders like Alzheimer's disease, people have looked at the structural and functional neurosignatures of these conditions, and I think that can certainly be a very fruitful pathway. In functional neurological disorder, I think what's interesting is that I don't think there's going to be one neurosignature. If we use the analogy of our brain as a computer, and what we'll share with patients clinically is we can think of largely, by the way, the hardware at a macroscopic level is healthy, but the software is crashing. And there may be multiple ways that the software can crash. By the way, I led with structural imaging. So yes, sometimes the software is crashing because the hardware is crashing. But as we delve into this, and in the last few years, my lab has been fortunate enough that we've collaborated with other groups who've collected their own data. And I can share with you all that while there are some interesting overlapping and complementary findings, not all the findings are replicatable. And I think with so much heterogeneity, we need to think about there might be several networks that can be perturbed, and there might be a number of perturbations that give you a final output. The software is crashing, and it's hijacked my volitional motor circuitry. So those are a few ways we're thinking about this, but that was a very good question.
thank you.